Maybe, oh, there we go. Never mind.
Okay.
I think we're good to start, right, Chris?
Yes, you can go ahead and get started.
Okay, welcome. We are so excited you chose to spend your lunch with us today. We're going to do a quick round of introductions to tell you who we all are, and then we are going to go ahead and dive right into the presentation. So if you're here to see what would you do if the use of ethical decision-making in consultation and trauma work, you have come to the right place. I'm Dr. Susan Foster. I am the department chair of the Counselor Education Department online at the Chicago School, and I am a full professor. Tag Dr. Rush Wilson, you're it.
Thank you so much. I am Tiffany Rush Wilson. I am the Associate Department Chair, and I will tag Dr. Dixon.
Hi, I'm Dr. Cody Dixon. I am the Director of Clinical Training and Associate Professor here at the Chicago School. And Dr. Eldridge, Dr. E.
Hi, everybody. I'm Dr. Eldridge, and I am a full professor in the Counselor Education online department, specifically clinical mental health counseling at Chicago School.
And so we are going to dive right in. So you can advance the slide, Dr. Dixon.
There we go.
So we have 5 specific learning objectives that we're going to cover today. I have to move everybody out of my way. 1 second. There we go. We're going to effectively assess how trauma shows up in counseling, identify appropriate trauma-informed decision-making models, apply trauma-informed ethical decision-making models to case studies, identify trauma-informed consultation strategies, and also apply trauma-informed consultation strategies to case studies today. So some tips for maximizing today's workshop. Feel free to ask questions. You can put those in the chat. Cassandra and Colleen, I'm going to ask you guys to monitor the chat to see if we have any questions, and feel free to just stop us and we will take questions as they come. There will also be a question and answer period at the end of today's presentation for those of you who'd like to come off mute and ask questions at that time. So we also want you to look for the light bulbs during the presentation. These are specific strategies that you can go into your practice, whether it's counseling or supervision, and employ those strategies immediately. Also look for the sunglasses during the presentation for some unique takeaways. So, Dr. Dixon, you can go ahead. I don't know that we have a poll. We'll just use.
Hey, we're just doing it verbally or in the chat. Dr.
Yeah, we'll
Foster.
use the chat. Poll question 1. Does your disclosure statement indicate that you will use consultation? So go ahead and just pop your answer in the chat, and Colleen, if you could just tell us where we sit when. Take about 30 more seconds.
Dr. Foster, it looks like most people are saying yes, that their disclosure statement does indicate that they will use a consultation. We have a couple people that said that they don't know, and we have one person that said no.
Okay, well, after today's presentation, we will come back and ask this question again to see if it's a necessary component of a disclosure statement. You can go ahead and advance the slide, Dr. Dixon. So, as an assessment person, I drew the lucky straw. I'm going to talk about objective 1, which is effectively assessing how trauma shows up in counseling. So there are a couple of things that come to mind, and I actually asked this question of some clinicians as I was putting together my part for the presentation. around trauma-informed assessment of concerns. And what became apparent is without trauma-informed assessment and screening, a couple of things can happen. And so that's why it's so vital for us to talk about what this looks like in terms of ethical practice today. Clients' trauma histories and related symptoms can often go on undetected if we're not routinely checking in and assessing around trauma. Counselors may partially or fully fail to provide the support that clients need around symptoms and disorders. And counselors may fail to identify risk of developing more pervasive or severe symptoms of traumatic stress, suicide, self-harm, or homicide if we are not actively and appropriately assessing client concerns. You can advance the slide. So SAMHSA does a really good job of talking about what it means to have trauma-informed practice. And so as we're talking about trauma-informed practice, especially as it relates to assessment, I'd like for you to open up your mind and think about, I'm not just assessing my client, but I'm also assessing myself in terms of what's going on. Because any good assessment, we're looking at how we show up and how the client shows up when we're trauma-informed. So first being safety. Staff and clients feel physically and psychologically safe, including physical setting and interpersonal interactions. Trustworthiness and transparency. Organizational decisions are made with transparency with the goal of building and maintaining trust between clients and staff. Peer support. There's this mutual help, and this goes along with the idea of consultation, this mutual self-help and support among peers to help establish safety, hope, trust, collaboration, and promotion of recovery and healing. Collaboration and mutuality, which is such a hard word for me to say. Importance is placed on the partnership and dismantling power differentials among staff and clients. The organization values that everyone has a role to play in a trauma-informed approach. Empowerment, voice, and choice. Clients and staff strengths and experience are recognized and built upon. Individuals are supported in shared decision-making and goal setting to make choices that are best for them and their healing. And then cultural, historical, and gender issues. The organization recognizes and addresses historical trauma and works to move past cultural stereotypes and biases. Gender, racial, ethnic, and cultural needs of the clients and staff are met. You will notice that when we are using a trauma-informed approach, everyone plays a part in what this is going to look like. And so you'll notice that the ideas of ethical decision-making, collaboration, consultation are woven throughout this. The idea of using a trauma-informed approach is that no man is truly an island, that you were never intended to sit in a silo and do trauma work. I suppose you could, but you run the risk of burnout, vicarious trauma, longevity issues, making ethical missteps, making legal missteps. You can advance the slide, Dr. Dixon. So guide point 1, you'll notice the little light bulb when the questions become the answers. Especially for the supervisors on the call, I'm going to share what I like to call a modified fishbowl in a few minutes that really look at these questions. So I want you to think about the context of the 6 key components of trauma-informed care as we go through the next set of slides around assessment. You can advance the slide. So as I indicated earlier, this idea of assessment is twofold: client assessment and clinician assessment. You can advance the slide. So when we're looking at client-related concerns, we should be doing a 360 review of what is going on with our clients. And again, this is rooted in SAMHSA. Trauma-related symptoms, depressive and dissociative symptoms, sleep disturbances, intrusive experience. Regardless of the orientation that you subscribe to, you should still be looking at past and present mental disorders, including typically trauma-related disorders such as a mood disorder. Severity or characteristics of specific trauma type, for instance, interpersonal violence, adverse childhood experiences, combat experiences. There is a cautionary tale with this. That is not the only way that trauma shows up. And Dr. Rush Wilson and I were just talking about this yesterday, how it shows up. Substance use, social supports and coping styles, availability of resources. I was having a conversation with a group of students on Friday around resourcing. And how easy it would be for us just to say, well, you know, what might be helpful is for you to go do this, this, and this. These would be some fantastic resources for you to receive some trauma-informed support. Knowing your client will help you understand whether that is even feasible for your client at all. Risk of self-harm, suicide, and violence, and then also health screenings. So another poll question here, impromptu poll question. In your disclosure statement, how many of you, can you go back? There we go, Dr. Dixon. How many of you suggest or request that your clients get a full health screening or a physical from their medical professionals? 1, yes, 2, no, 3, I don't know. So go ahead and pop that in the chat. And Cassandra, if you could tell us the answer when we'll give about 30 more seconds. All right.
Lots of yeses, lots of ones, and a couple no's.
Okay. I'm going to tag Dr. Rush Wilson because we talk about this all the time. Dr. Rush Wilson, I know your specialty is in disordered eating. However, from a trauma perspective, what does your disclosure statement say and why?
The entire disclosure statement, I do indicate
No,
that.
around this, I won't make you repeat the whole thing.
Okay.
That's like reciting Macbeth in high school. I won't make you do that.
Not only do we indicate that we have to consult with other people occasionally, we also indicate in my practice that we only function in a multidisciplinary team approach to make sure that we cover all the bases. So we want this person to have access to, of course, absolutely is imperative, medical evaluations, because there are medical complications associated very often with disordered eating. And then we also have group therapists. We have couples counseling. Sometimes that's a part of the treatment, depending on what's going on. Family therapy. There's so many different moving pieces and parts to that type of treatment. So in the informed consent and the disclosure statement, we do let everyone who comes into the practice know that all of those components are necessary in the practice.
And Dr. Dixon, Dr. E, I'm going to tag you because I know that your work is different in terms of the trauma that you see in your office. What would be the rationale for you as to why your clients would need a health screening?
Well, a lot of times trauma shows up in the form of our body, pain, digestive issues, endocrine issues, so we have to be careful not to only look for the trauma symptoms in one specific category. We often think about flashbacks or nightmares, but especially across cultures, across, gender identity, age, trauma shows up in a lot of different ways that may be better detected, but also necessary to treat from these various entry points. If that makes any sense.
Yes, and as a therapist who sees a lot of trauma in my practice, I also recognize the scope of my competence, and so I'm not going to necessarily assume that something is or isn't trauma related. They need a good health screening to help make that determination, because I am not that kind of doctor. So there's also an ethical scope of competency issue in terms of how we assess. You can advance the slide now. So this is the modified fishbowl for guide point 1 that I was talking about. I think really when we think about our clients' trauma and using a trauma-informed approach with assessment, really digging in and asking all of the questions. And so I'm going to put my colleagues on the spot again. I'm actually going to start with Dr. Dixon this time. Dr. Dixon, you have a client. I know that you do a lot of trauma work with forensic clients. You have a client who walks into your office and using a modified fishbowl approach where you're really taking that 360 look. Give me a question that you might ask using this approach. What questions might you ask your clients to help guide that discussion?
Sure. I think one of the things is, especially because I work with forensics, is what brought them here, and what motivations do they have to be here? To focus on, are they here only because they've been court ordered to do so, because they're under a judge's order of some sort within a specialty court, probation, parole, someone make them come, or did they come of their own volition?
And for me, it might be also be a where and when. I do some forensic work as well. Where does the trauma happen? When was the last time the trauma happened? To know whether or not, my potential client is still really in the thick of what is happening. Dr. Rush Wilson, what might a question be that you ask?
I ask my clients, what is it that you want from me? What is it that I can do to be supportive of you?
Dr. E.
I was just jotting down some thoughts. I would want to know for the what do they want me to know right now, knowing that, we don't, and nor really should we expect to get the whole trauma narrative in the first few episodes. That's not safe to do. So, here as we begin, what would you want me to know? And then I might follow that up with a how, like, how would you know when you're ready, when you feel ready or resourced enough to maybe take one more baby step towards processing the trauma, and letting them know, like, and this might be the context of my work, because I work in private practice, so I don't have, I'm not adhering to courts or outside parties, so I might have a little more freedom in having it be like, whenever you're ready. We have no timeline here. So that might look different for others.
And I think my why is determined by the client. Why am I here? What do you want this to look like for me? So again, this is a 360 approach, and it's you assessing yourself as much as you're assessing the client, thinking about the setting, what it is your client wants to have happen, what particular freedoms you have, who are you having to report to. Because the who, as you mentioned, Dr. E, also creates safety concerns, and making sure that we are in this 360 holistic assessment of our clients, we're ensuring for their safety. All right, you can advance the slide. So, ethical takeaway, there are sunglasses. I love these things as an educator. You'll note that it says on the drawing, please note if I made any mistakes in this test, perhaps a picture of a draft will convince you otherwise. And so the ethical takeaway is that planning and execution are really vitally important in terms of assessment. Thinking about what does that look like? If I had thought ahead, I might put another poll question that asked about what assessment looks like in your individual practices. Lots of times people will tell me, oh, yes, we work with trauma, but we do not have an assessment protocol. As you sit and you think about the things that we're talking about today, do you think that that's ethical and safe to not have an assessment protocol? So really, the planning and execution of assessment are vitally important. Dr. Dixon, you can advance the slide. And again, like I talked about, here's another one of those light bulb moments. A self-assessment, if you're going to be doing trauma work, ethical practice dictates that we are really aware of how we're showing up. There are a multitude of assessments out there. I chose to focus on the professional quality of life scale. It's free. It's been translated, normed. The psychometrics around reliability and validity are fantastic in 18 different languages. And so no matter what you choose, make sure that you're looking at the psychometrics. Again, it's been developed to measure both the negative and positive effects of those working with individuals who've experienced trauma. And there are subscales that really look at compassion, satisfaction, burnout, and compassion fatigue, which all of us work in trauma and all of us can tell you we consult on a regular basis with each other. And the idea of satisfaction and burnout and compassion fatigue are real. Dr. Dixon, you can advance the slide. And if you can make that a little bigger, I don't know if you can. I did screenshot what this looks like. It says, have you experienced these things in the last 30 days? What does that tell us? It says that we can take this often. I have it set just like any other appointment on my calendar. That is a big takeaway. I routinely do this. Every 45 days, I'm looking at myself to say, where am I at really with my practice of working with trauma? And so, again, it's free online. I'll find I'm actually going to ask Colleen, tag Colleen, you're it. If you could find the link, Colleen, and pop it in the chat for anyone who wants to use it as a resource. And again, it's not specific to how is trauma showing up in your office. It's how am I showing up in my office while working with whatever it is that I'm working with. Dr. Dixon, you can advance the slide.
Oh, squeeze right there. Pretty difficult. Lost my mouse there for a second. There we go.
Other takeaway, self-assessment of strength is important. And you'll see how this child did it, how many days are in a week, 7, how many months are in a year, 12. Is the number even or odd? 68, it's even. How do you know? Because I'm smart. So self-assessment of our strengths and really understanding where we are is vitally important to the process.
There you go. Now, objective number 2, that is myself and Dr. Tiffany Rush Wilson. We're going to identify appropriate trauma-informed decision-making models. Go on to the next one. But we wanted to first kind of cover, and we appreciate that this was in here from that Dr. Foster added it for us, talking about law and ethics. And it's very, very important. And it goes back to all of us when we were first in class, learning the difference between law and ethics. And that is pretty much what's the difference. To narrow it down, law can get you fined, put in jail. You can have legal things come up against you. Ethics may break the law, but ethics will be a loss of credential, other sanctions against yourself, your license, your practice. So we will go into some discussion as we go on about different things being unethical but legal, and legal but unethical, and different ways of looking at those things from that lens. Dr. TRW, do you have anything to add?
I think that last point is very important. Law allows us to help make good decisions. It helps us identify what things are facilitative and helpful. And ethics do that. And law also is designed to make sure we maintain social order and protect people. There's often overlap between the two. When there is any difference between the two, make sure we always obey the law and then consult about how we integrate ethics in the law when they don't align completely.
Dr. Foster, I'm going to call you out for a second because I know you have a keen interest and background in some law and ethics as well. Do you have anything to add?
Just because you can doesn't mean you should.
Very much.
And that is one of the things I drive home to my pre-licensed supervisees. Just because you can do something doesn't mean you should, such as working with trauma. Just because you can doesn't mean you should. Really digging in and looking at what are the legal ramifications to doing something that I'm not properly trained in. What are the ethical ramifications? So that would be my big takeaway. Just because the law allows me to ethically, that doesn't mean I should. So just because you can doesn't mean you should.
Absolutely. Okay. Dr. TRW, you want to start us off here?
Sure, there are many different ethical decision-making models available, but for the purposes of this discussion, we're going to talk a lot about trauma-informed ethical decision-making models. And within that, we had a really interesting at least I thought, a really interesting conversation this morning about why do we even need to talk about trauma-informed ethical decision-making models? Because aren't all ethical decision-making models trauma-informed, multiculturally informed? And the answer is, depending on the clinician using them in the interpretation of those models, the answer might actually be no. So the assumption that I will say that I made, and some of the other people in the conversation this morning made, is that yes, of course, we include trauma-informed care and multiculturally based ethical decision-making in all of our work. That might not be the case for some people, so we need to have an emphasis in particular on explicitly stating that trauma-informed ethical decision-making models are a thing, and they do include multiple aspects of seeing a person's life from many lenses so that we can make the most protective and informed choice for the clients we serve.
Yeah, I would add here on the trauma-informed and multiculturally informed client, if our counselors, if you go back to Dr. Foster's section above, where she talked about the SAMHSA 6 considerations when it comes to trauma-informed approach, is the last one on that list basically was historical, cultural, multicultural. And we had this conversation earlier with our colleagues trying to figure out, can you really divorce trauma-informed and multicultural informed counseling as being separate things? Are they? And we really kind of came to the conclusion among the four of us that you can't, because there's always, regardless of the situation, there's always that multicultural component or that cultural or historical component that is connected with an individual in counseling, but especially within trauma. And so we talked about that for a good hour. And then we talked about, what messages are we sending our clients with our body language and with our approach to them if we are not trauma informed? And we had a really hard time as a group talking earlier, is like, not sure that any of us really could separate ourselves from being trauma informed, because it's something we're so ingrained in doing at this point. And just talk about, what, and we'll have, what we do, what messages we send when you're dealing with a client, like we've talked about, your reaction to their trauma, your reaction to their stories, your reaction with your body language. And some of the examples or case studies, keep this in mind, because it'll be a very important part of what we talk about. Dr. Tierney.
And we also talked a little bit about making sure we're very careful with the language that we use, even when we're making very quick decisions, like how to respond to something. So for instance, if a client comes and tells you they're pregnant, we don't necessarily want to jump off with congratulations, because it might not be something that they are excited about. Or we might not want to say, oh, I'm so sorry to hear that if this person has multiple children, because maybe this is something that is really important for them. So understanding how to approach someone, maybe even asking, well, how do you feel about that? And they will give you enough information to help you construct the appropriate response to the news that they deliver to you. Because there could be trauma underlying how that pregnancy was even conceived. We don't know until we ask.
Absolutely. And then kind of moving on. So as we were doing our research and looking at different ways that we wanted to discuss ethical decision-making models and trauma-informed work that we do, or trauma work that we do, we came across this article that just came out in about May. So it's about a year old, May of 2022. And we really liked this article and this study, because it took a lot of things that Dr. Foster had already talked about up there, the SAMHSA factors and the ACEs scores for adults and children. When you're scoring those, it took into consideration several different ethical decision-making models, but then also taking into consideration all these different developmental and other factors, principles that we need to take into consideration while we're working with these clients. First of all, we'll just kind of go over them, and please feel free to pop in if you have any questions or anything. Same thing with you other faculty members, panelists. So attachment, developmental considerations, talking to your clients about those things. So when you're doing that biopsychosocial in the beginning, like Dr. E said earlier, And Dr. Foster said earlier, when do you start digging into the trauma issue? When do you do those things? And really, if you consider the fact that you need to look into during your intake and during your sessions with individuals, what attachments do they have? What do those look like in the past? What do they look like now? How are they developmentally? All those kind of considerations we think of when working with, kids or youth or anything. Don't forget those things when you're working with trauma patients as well, trauma clients as well. There are all kinds of things that come up that may find them, having to consider these attachment and developmental issues more heavily than maybe a client that did not experience some trauma. Let's see. A good one. We go back. I actually had a hard time, Dr. Foster, keeping my mouth shut when you talked about having a client go to a doctor. It's in my initial documentation with my initial informed consent and my initial intake with clients that I want to know, are they currently under the care of a medical doctor? Are they currently under the care of any other psychiatric care? When is the last time they saw their doctor? And then I like, depending on their age and the things that they're presenting with, I like for them to, return to their doctor and ask their doctor to go ahead and have them checked out, do a physical, do some blood work, find out if there's anything that needs to be further tested. As Dr. TRW said earlier, I explained to them that I like to work in as a team. I have a current client, she's a trauma client I've had for a few years. It is me, her psychiatrist, and her medical doctor. We talk regularly because she sees all of us regularly. With many of the things that Dr. E said, she has had or currently has at different times a defined pain disorder. She has had diverticulitis, stomach issues, pancreatitis. She has celiac disease. They thought at one point she had juvenile diabetes. There's so many health issues that come, and a lot of this is related obviously to her trauma, but then also some of her past abuse. So having that full medical checkup, especially when a client is talking about those things, is so very, very important. Dr. Ashworth?
Another thing to keep in mind too is the intersections between many of these points identified here, and how for many people, these things aren't separatable. So for instance, if we're looking at someone's self-concept, that might not be separate from their protective behaviors, their minority stress, their historical traumas. All of those things might be just different pieces of a larger system for an individual person. I am supervising someone who is seeing a client who is an older African-American man who is starting to have some cognitive decline. And in that presentation, this person's behavior is wildly, vastly different than it used to be. We do know that this person has had sustained injuries. They had a sustained head injury. We also know that this person has dealt with many, many years of racial trauma. Their behavior now can't be separated from any individual piece or part or identity listed here because they're all intersected. There could also be a medical condition going on with this person because they sustained a head injury. This person has been an African-American man in the United States for 7+ decades. There are many, many things going on. So we have to look at this person's behavior, despite the fact that the family sees most of what's going on as normal because it's been their lived experience, as potentially trauma influenced. And then we have to approach it through a trauma informed lens. It's really important to see this person, even if they are used to the tragic or traumatic events that they've experienced, there still can be neurologically a trauma impact that this person evidences through their behaviors and presentation.
Yes, I would like to ask Dr. E or Dr. Foster, with your experiences working with clients through trauma, just with these first few, the attachment, the physiological, and let's say the intergenerational that we'll talk about as well. What kind of factors do you see that come in with your client work here that we may have missed?
I mean, what strikes me, I'm thinking about a few clients of mine specifically, what strikes me is how important it is for us to be able to speak, offer psychoeducation in a trauma-informed way, which means no psychobabble, not being condescending or know-it-all, but being able to provide the information to our clients about the impact of trauma, including intergenerational trauma, and how trauma is expressed in our nervous systems and in our bodies, and how even, our grandparents' nervous system influences our nervous system. And so, it's a really, if we can do it effectively, it can be incredibly destigmatizing and empowering for the client to say, like, oh, you mean like I'm not just crazy, or I'm not weak, or I'm not neurotic. No, like this is any nervous system that experienced what your family has experienced and has gone through these, experiences in culture and society and all this stuff is going to have these extra stressors put upon it. And so this is one way that our nervous system adapts and it helps us survive. But here's the flip side of that survival adaptation, is that then sometimes it leaves us with some extra pain, extra nightmares, extra emotional dysregulation. And so being able to share that information in an empowering way with our clients, I think is just a critical, necessary, a must do element of trauma-informed work.
Absolutely. Dr. Foster?
I agree with everything that Dr. E said, and as you all were talking, and as Dr. Rush Wilson was talking about the intersection, and Dr. E was talking about destigmatization. One thing that I am hyper aware of when I'm supervising my supervisees is really working with them to recognize that quite often it's not what you say, it's how you say it. And my students know I don't love the words typical and normal. I don't love that because, again, as an existentialist, I believe that meaning is such a personal thing. And it's not for me to tell my client necessarily what their trauma is supposed to mean. It is my responsibility, as Dr. E talked about, to talk about the mechanisms that underlie trauma and why we respond the way we do. And so I think the other really important thing around trauma-informed ethical decision-making is, again, that crucial piece of how are we showing up? Have we done our own work? Are we monitoring what we say and how we say it to our clients to really not just destigmatize what it means to have experienced trauma, but also to build that. I think about clients and them telling us their trauma narrative and how you may be the only person they've ever shared with, and what an awesome responsibility that is. And making sure that we hold space for that, whatever that looks like. We hold space in terms of how we provide psychoeducation. We hold space in terms of reflecting back the pain that our client has experienced or is experiencing. And so recognizing that sitting at that intersection with your client may be one of the most difficult and challenging things that we do as individuals who work with trauma, and the awesome responsibility that goes with that. So that's what was coming up for me as you guys were talking about it.
Absolutely. I said here, and as you guys talked, I was ready to move on to a few others. And then, I have a hard time getting away from the intergenerational and the historical trauma that we were talking about, for not only for clients, but it also goes into, what messages we're sending our clients with our own generational issues or historical issues that come up with us as they're sharing their stories, and being able to dig deep with clients into those issues. I tell this story often, but every once in a while it kind of comes up where years ago I was teaching ethics and marriage and family therapy class in the same class. And I had students that were really thrown about the fact that they hate doing the genograms and they hate doing all the family work. I don't want to work with families. I want to work with individuals and doing all that work. And then I had one student after she graduated call me and said, you know what, I hated doing it, but she immediately got into her job and she worked at a trauma place where the first thing they did was a family tree on everyone. And they talked about intergenerational issues, historical issues, trauma being a common part of their family history. Situations where, every child in the family may have experienced something. And so I think you could go on for days and do a lot of work just on the intergenerational and historical trauma stuff. But it is so very important.
And Dr. Dixon, can I jump in?
Yes,
Sorry, the rest of it. What you've now got my wheels spinning, and I'm just thinking about this parallel process of trauma-informed care for our clients. We have to be trauma-informed for ourselves, that if we are not able to, let me sit and check, like, what's this reaction coming up, or what is my family history, or what are my wounds, we are going to get tripped up big time. Which will then send us into a non-trauma informed care approach with our clients and potentially re-traumatizing or newly traumatizing interactions and dynamics with them. So to your point about, a lot of these assignments that counselors in training have to do that really cause a fair amount of discomfort, know that there's a purpose to them. The purpose is not just to make you uncomfortable. But it's part of developing ourselves with a trauma-informed professional identity.
Absolutely.
And along those lines too, Dr. E, we have to keep in mind too that as counselors or as counseling supervisors, we may hear traumatic events with some regularity, and we can be sometimes desensitized a bit to hearing a new trauma or a client or a supervisee sharing their trauma. And we have to keep in mind that trauma is personal. It is idiographic, it is individual. And someone may be sharing something with us that is incredibly traumatic for them, but might be 30 times less traumatic if someone were writing out all the traumas that one could experience that we heard from another client. We have to make sure we're not doing anything comparative and allowing people to be in their space. A client not too long ago shared with me something that was really traumatic with her, and it took her probably a full 7 minutes of just sitting in silence and crying before she could share what the thing was. It was something that if I were to share what the specific thing was, many people would probably be surprised it was this difficult for this person, but it was. So to sit there and allow her that space and allow her the ability to get up the nerve to share that this thing happened in her life, and then to gauge my response, was really powerful for her. And it was actually really powerful to me that she was willing to share this event with me and to ask me, do you see me any differently now? No, well, in a way I do. I see you as very brave for being willing to share something that was so hard to discuss with me. But is your worth reduced? In no way, shape, or form. It's never even crossed my mind. And it was important to share those things with her because it was a part of her entire trauma narrative.
Absolutely. Thank you. So then as we move on, minority stress, cognitive schemas, things like this. So we were talking about this earlier as well, Dr. Rushbushel, when it came to like just the stress of different populations and how we need to consider all of those other cultural factors when we're looking at, what stress, what is their trauma, what does trauma look like for them, what does trauma look like for their community, how do we incorporate just that overall life stress and how they view the world or again, it also goes with the cognitive schemas, how they view the world, how they view the interactions around them, how they develop their own understanding cognitively of life functioning around them, and how they develop schemas for, as you're talking about multicultural groups, schemas of the other, schemas of other people, schemas of what a whatever the trauma level was. I can tell you this, one of the most interesting things that I've run across working in the criminal justice system is the vast number of people that actually come into the system with trauma, and their trauma being car wrecks, being rear-ended in a car wreck. Then they have an injury, and that injury results in them starting to use a drug. And then they start using an opiate or something like that. And then it just kind of goes down into this deep dwelling of trauma based on a car wreck. And what's interesting is I've seen it in various different levels of people, is you see someone who's wealthy enough, has full insurance, that can get all the care they need, and these things work for them, as opposed to someone who does not. And so they develop very different schemas. They develop very family related stresses. They have community stresses around the fact that one person can get the care while the other one can't, or that the other does and the other can't. It just gets into how they view the world around them, and stuff like that. Do you have something to add there, Dr. Rush Wilson?
No, just that we do make the best effort when we're making decisions for our clients to reduce the potential of iatrogenic trauma and harm, so that we don't have a response, a reaction, a statement, a look, a glance that compounds whatever this person is experiencing and making it worse.
Yeah. Self-concept, basically, and I'm sure that Dr. E and Dr. Foster and the others can input some thoughts on that one, because it's like the overall, like, you have to consider that individual client self-concept, and again, your own, which we'll talk about here in a minute too, of how they are now viewing the world and viewing themselves after this event, the traumatic event or whatever thing has happened with them, and with how they're being treated by the others around them, and how they view themselves, and how they again, like below, like how they feel protected. Do they have the behaviors to protect themselves, and what do those look like? Do they have family support and community support? Like, all of these things get so tied and intertwined together, it's hard to separate them from the other. But that's especially true in developing an understanding for trauma-informed ethical decision, because you have to think about all of these things, keep every one of these factors in mind, while you're also working through an ethical decision-making model to decide what you want or how you need to approach a specific ethical dilemma that you may have.
Dr. Dixon, can I jump in on the protective behaviors?
Absolutely, anytime.
I want to share from my mistakes. I often find that's the most helpful way I can teach and train is,
Right.
thinking about my development as a counselor and as a trauma-informed counselor. I, in the beginning, and honestly still struggle with this sometimes, but a lot of our clients, especially clients with extreme or complex trauma, their protective behaviors are really challenging for other people, including for the clinician. And when we're not seeing them through the trauma-informed lens, we tend to take it personally. We tend to, let that chip into our self-concept of I'm not good enough. This person hates me. I'm never going to be a good counselor. Like all those narratives that so many of us, I know we have. So when we can shift that away from being a personal affront to us, because I'm thinking, the common protective behaviors might be pushing people away.
Mhm.
It might be destructive substance use. It might be lashing out. It might be you're the best counselor I've ever had. You're the worst counselor I've ever had. It might be threats to our license or to our reputation. I've had all of those. And when we lose sight of the framework of this is trauma informed, this is protective for the client, we get into our own trauma response, which is, that fear-based response and all of those self-concepts and schemas that we might have. And that opens the door for us again to be unethical or re-traumatizing or get burned out, vicariously traumatized. We'll keep talking about this, I know, as we go. But so I guess I just want to say that for me, that one jumps out even above all the others, just on my own experience, to really make sure we know what all kinds of protective behaviors are and to hold ourselves, give ourselves a pause, I guess, first when we're feeling like our clients are reacting in a way that doesn't feel good to us, to check and say, like, how might this behavior be beneficial to the client in some way, and spending some time on that.
Yes, and you're absolutely right too. When you said before, it's like, learning from our own mistakes, right? And I think one of the big mistakes, and I have plenty, we could do this all day, but one of the big mistakes people make that I wanted to make sure we did cover today when it comes to trauma informed is also not assuming something that we see as a traumatic event is actually affecting that client in that way. I can tell you, I've had plenty. I have one that I finished with a few years ago. She came to see me for relationship issues, and her boyfriend, who was just, he just wasn't a good guy. That's where she had to come to that realization, right? But she had been sexually abused by an uncle when she was younger, not many years before, maybe 5 or 6 years before. And everyone she saw, and she kept going to different counselors, and everybody kept trying to trauma her, like trauma counselor. That had to have been this thing. And blah. No, I brought it up one time, and she gave me the most beautiful answer. And I was like, we never have talked about it again. What happened with her perpetrator in this particular case, her uncle that abused her, was the family, the community, the law enforcement, the treatment at the time, everything came around, protected her from that family community factor. It became not a traumatizing issue for her. It was an event that happened in her life, and she clearly didn't like it and didn't really like, but it did not define who she was. And she was not interested in talking about it, not because she was trying to avoid it, but counselors, and she would see multiple counselors, and they would always try to dig into, well, your relationships are related to your trauma. She's like, no, my relationship issues are related to, truthfully, he was a bad boyfriend. But to tell a client, to imply to a client that the thing that happened to them was so horribly traumatizing that they must go through some trauma therapy to deal with it is extremely unethical and just flat wrong for some clients. I see Dr. Edie, you have something to add. You're kind of nodding, going, oh,
Yeah,
yeah.
I was just thinking back to the trauma-informed principles of like voice choice. Like, it's not our voice that says what the trauma is or how it makes sense or what it means to them. And it can be a little too easy for us to be like, oh, I know that model. I know how that's going to impact this and that. And yeah, it's the client's voice that we need to listen to.
Yeah, and the voice I needed to hear from her was the voice that me and my boyfriend have a bad relationship, and the factors related to his family, his environment, his history, his abuse, his things, not hers. And so, that really changed things, Dr.
That reminds me of many years ago, I assessed a child whose parent wanted them to be seen because the child was, I'd say you could call it sexually assaulted. Somebody attempted to rape a child, and the parent just happened to walk past this isolated, secluded place where this attack took place. So the parent walked up on this adult about to sexually assault their child. And the parent wanted me to assess this child to see if they were okay. The child is traumatized. This is so awful for the child. And that really is not the way the child perceived it. The child's version of the story was, this stranger did this thing to me, grabbed me, and then my mom showed up. And the way she always had these like eagle wing type things about how mom showed up, let me know that this child felt protected and felt safe by mom. The person who ultimately became my client was the mom, who had a lot of what ifs going on. Mom was by far more traumatized by what she'd seen than the child was with what they almost experienced, because the child's version was that they almost experienced it. They didn't process it as a trauma, but mom did.
Yeah,
so we do have to be very careful. We cannot assume that an event causes trauma for an individual. The mom was the client, but she was the unlikely client. She was the protector, except that's not how she saw herself.
Right. And then on our final one here, which again could go on for quite a while, let's talk about clinician health and clinician well-being. So you run into a lot of issues there. The first thing comes to my mind, and Dr. Rush Wilson, when we were talking earlier today, is, impaired clinician. You cannot be working with your clients, especially trauma clients. If you're bringing up your own stuff, if you're currently dealing with some of your own stuff, if you're simply not mentally or physically well, sometimes like it's really, if you think about it, there's an unethical standard to going into a session going, I don't feel very well. I have the flu out. I'm sick. I don't feel good. I'm not in a good place right now. And it's not even a big factor, but sometimes something as simple as just being ill, being sick, back of COVID, having COVID, things like that, and going into seeing a client, you can't ethically think clearly enough if you can't think clearly enough at the time. And that's some of the simple things we don't think about. We're like, oh, I'm not going to cancel this client. I'm going to go on in there and see them. It'll just be an hour. I'll be good and I'll be out the door. Right. Well, are you really giving that client your all? Are you really healthy, and is there good well-being on your part? And then the other part that you hear a lot of is, if you have gone through a trauma, or if you're experiencing a grief, your loved one, your mother, your father, someone in your family passes away, you may not be the best clinician to be working with someone who's dealing with grief at the time, and you might have to refer them out for a little bit. I've seen therapist friends of mine that needed to refer out for a good 6 months, because every time they were in the room with the client, sometimes they would just kind of get glossy-eyed and start thinking about their own issues. And then that again results in ethical missteps, problems, or just simply, which is of itself enough, just simply not being there for the client. Not being as active as you should.
One thing that someone shared with me the other day, Dr. Dixon, on that, was when we're feeling sick or tired, but we're still in the session with the client, especially for our clients with complex trauma, remembering that they are very likely reading every single cue in the room and wondering if they did something wrong, if they're in trouble, if something's about to change, if they're in danger. And so I know, at least in my family culture, we are raised to be like, nope, nothing's wrong. I'm fine. Everything's fine. Do I look tired? Nope, I'm totally good. Even though I'm like, I got 3 hours of sleep last night. And yes, clearly I'm not totally at my best. And so balancing the self-disclosure and not saying like, oh, let me tell you, I got no sleep last night, not making it about us, but saying, you may notice that my energy is lower today, or yes, you are right. When you ask me if I'm okay, I am tired. That's about me, or that's something that has happened for me. And I'm really glad to be here with you. And let's talk about what we want to talk about. So that's a reminder for me not to fall into my family culture of because then they're like, oh, so am I imagining it, or are you lying to me, or can I not trust my perception? And that's not helpful or trauma informed.
Absolutely. I think you made me think really quick on the fact that, they can sense a sense of dismissiveness so quickly, or interpret it as a dismissiveness. I don't know. Many of my clients, by the time some of them have seen me, they've been through 1, 2, 6, 7 to other therapists. And you hear often like, I just feel like they weren't listening, or they were dismissive of me, or it was about them, or all the things you just said, Dr. E. And they come in there. So I try my best, same as you. Yesterday, I saw several clients in a row. We have the conference going on. My mind's not where it needed to be with them. As we're walking in, one of them's like, oh, feels like a Monday. I'm like, it does feel like a Monday. I was very honest with them both. Well, we had to have the conversation where, if I just seem a little off, it's just them just filling the Mondays and stuff like that. And they seem to respect that. And that's enough to give them. Just fill in the Mondays. And it works. Because you're 100% right. They sense the most. They're so hypervigilant that they sense everything, and personalize everything. Like you said, with your protective factors earlier. So that might result in screw you, you're not paying attention to me, or tears where you're not paying attention to me, or both. Let's see here, I'm gonna go down here for the next one. All right, Dr. TOW, I'll let you take this.
So we have to think about how we select the appropriate approach to ethical treatment. Because as we already noted, things can be legal, but maybe not ethical. Generally, if something is ethical, it'll be legal. But if we have any question or concern about whether or not something is both legal and ethical, we want to make sure that we consult. We don't make these decisions by ourselves. We want to make sure that we're providing the best possible care to our clients, to our supervisees, and to make sure that we are protecting ourselves, our profession, and the people who we treat.
So we want you to consider this little poll question real quick. It's you don't have to put the answer quite in the chat yet, unless you want to, but we want you to think about different. Quit laughing at me, Dr. TRW. We've really gone back and forth on this one. So is it unethical? Is it illegal to withhold, trauma-related behaviors and things that we see from our clients in progress notes? Where do those kind of things land? Excuse me. So think about it. Yes, neither, both. So think about that as we kind of go through our cases and stuff. Do you have something to add before I move on? And there again, we were looking around yesterday and just kind of literally just kind of dumbed across this one, but we thought it was really funny. So as the joke says, run it by illegal, but sprint it past ethics, right? So again, like Dr. Foster mentioned earlier, just because we can doesn't mean we should, right? So that's what this cartoon's pretty much saying is, oh yeah, that's legal. We can get away with that.
Mm-hmm.
Ethical as hell, but hey, whatever. So remember, you're not attorneys. Your job is to be an ethical, informed, well-trained practitioner. Now we're going to go on to applying these things that we've talked about to a case study. And so we, have some discussion there along with you guys. Do we have any questions before we move on to this next objective? Does anything come up in the chat or anything we've seen so far?
People overwhelmingly agree that that is a difficult question to answer,
Yes.
the poll question. So we
Good.
will get to that. And then the other thing that's someone said was not canceling patients is a tough one because patients are dependent on the availability of the session. We need more mechanisms for checking in on patients who may have needed that visit.
Absolutely. Great point.
All right, so let's go ahead and do our case study.
Yeah, so really quickly, so when you're putting together, we talked about this earlier, when you're putting together your disclosures, hopefully what you've gotten from the 4 of us so far, is to make sure there's a statement of consultation, make sure there's letting them know that you're using what code of ethics you're using. As long as you're using one, ACA, APA, whatever, just make sure you're using one and that you utilize ethical decision-making models and kind of what the steps and what those are. Let them know how you're multicultural and trauma trained and what your experiences are so that they understand what they're getting into. And if you're not trained in those areas, being clear that you are not trained in these areas. So our first case study we want to talk about, case of manslaughter. Sounds horrible, doesn't it? Is a very, very 20-year-old case of mine, but it's always hit me hard. I've always worked in forensics. I worked probation, parole, and different things for many, many years. So I want you to take into consideration, we'll call him James, this young man that I had. He is a Hispanic male, comes from a family with a very lengthy, very active gang history. Lots of alcohol, cocaine were family practices. You would get together, they would have parties at the house, and they would just like whole families be there. Like we're talking 50, 70 people in their backyard partying it up. Well, my young man, James, was a Golden Gloves boxer. He was actually only about 5'4" and about 138 pounds. He was a little guy, but built, right? So he's a boxer. One of his cousins, cousins, can't remember, someone roughly his age. And he was in his 20s at the time, young 20s, 20, 21. Challenged him, said, I could knock you out, James, I could knock you out. So they kind of get in that little pose and everything. James and all of them are high on coke and alcohol. James hits him one time and kills him. He hits him in the head, causes some internal bleeding. The head hits the ground and the man dies. He is charged with manslaughter. He's sent to prison for 17 years. So keeping those historical and family facts in mind and his culture and everything, he's already experienced that. He's now killed a family member and the entire family now hates him for it. He is now in prison for 17 years, go 17 years forward. He gets to me. He's coming to counseling for the first time. He is in a reentry court program. He is out still using cocaine, still dealing with 17 years ago with how his family hates him. He has no support. He is alone. He has no one. He's still using cocaine. He's going to court. And every week in court, the judge is ordering him to jail because he keeps popping dirty for the cocaine. But in our conversations, I am having this discussion with the judge and with the team and with everyone else, and being very careful goes to the progress on the things I'm documenting, because my attitude was he needed a long-term treatment now, that his current use of cocaine was a factor in his own poor coping, not the fact that that was the big deal, where court continued to put him in jail every weekend for 3 days at a time. My view was not to view the cocaine. So was it unethical for me, or illegal in both, for me to dismiss the cocaine use for the continued, even though we're talking, don't get me wrong, even though we're talking about it in the sessions, is it wrong to dismiss the cocaine use for the greater good of getting him into treatment, because you are not going to stop his cocaine use in his current situation? So how would you manage that ethically, and what would your decision-making model, what are these factors would you consider? Dr. Foster, anyone else? I see your face, that's why you got called.
I'm just thinking about how similar it is to another case that I worked. You know what, Dr. Dixon, I would love for individuals to come off of mute or use the chat.
I would check, I'd love it. I mean, I clearly have my own opinions because it was really my case and it's what I chose to do. So was it unethical or not? Keeping in mind, I want to be very clear when you're thinking about this, his charge was manslaughter. So there was a very small window of locations in which this man could go to treatment. He couldn't just go down the street to a lockdown facility. This is going to take him far and require heavy legal action.
So we have someone who raised their hand. So I think, Jessica, I unmuted you.
Hi, can you guys hear me?
We can.
Hi, I just wanted to say this is right up my alley. I have just graduated from the University of Cincinnati with a substance abuse counseling degree and a degree in correctional rehabilitation. So this is right up my alley. And I deal with these cases daily at my current internship. And I actually struggle with this because I grew up in the foster care system, and now that I've survived it and made it out of it, and now I have the ability to help others in similar situations, I would like to say that I would probably keep this cocaine use to myself, thinking that it was for the greater good. But I would also like to say that I would ethically do the other thing for my agency, because I don't think they would agree with that.
Yeah.
So I often find myself asking myself what my morals and what my ethics are, and then I have to compare that to who I'm responsible for, what agency I'm working for, and they usually do not line up.
Yeah, I have a question for you, Jessica.
Okay.
From a consultation perspective, so being in the pickle that we would find ourselves with this guy, and using your ethical decision making, who in consultation, who would you consult with if you feel you couldn't talk to someone at the agency, you don't want to talk to anybody at the court? Who would you consult with?
Client. I think it's the only person that matters. I think I would try to go down that path as long as I could without breaking any laws. Meaning I would try to give myself as much more time to suss it out. And if I don't know, if I found myself really believing that long-term residential treatment would be the proper solution for this, I would do absolutely everything in my power to try to first stop him from going to jail every weekend, because that isn't conducive.
Yes.
Well, this is a really tricky situation, but it also makes me realize I'm in the right field because I really care about this. So thank you so much for this.
Sure. Anyone else or anything in the chat, Dr. Foster?
So in the chat, we have, I need to consult before I answer. Were you acting as a mental health or addiction counselor?
Mental
And
health.
then there was a congrats to Jessica. And then someone said you are correct to advocate for your client. And then someone said, here is where a harm reduction perspective may be considered.
Absolutely. Good answers.
So I'd like to just bring up 2 more points and we can discuss. Number one, I'm not going to assume everybody is a counselor, but what does the ACA Code of Ethics tell us about withholding information? That's number one. And then the number 2, what am I legally in this situation, or I should say you, Dr. Dixon, what were you legally required to report back to the court?
Okay. So because he does have a limited level of confidentiality in the court system, and because he was in a reentry specialty court where we're in front of a judge, both of us. So you have to think, when I'm standing in that courtroom, I am technically on the stand. So typically what I would do, first of all, he's going to fail the drug test. I would often be honest, I'd often put myself in places to which I would try my best to not answer the question and keep it, keep it as I would if I were testifying, which is, did he test positive? Yes, he did. They typically would not ask me, did I know about that? Did I know? Yes, because one of the things he would often tell me was, I want to go to treatment. He would tell them, I want to go to treatment, and I will keep using cocaine until I go to treatment. So he's using it to trigger them to send him. And we would have those conversations. And the court just saying, no, we want you to, which was so stupid. We want you to show us you can stop for a week. Right? How genius was that? You need to show us you can stop for a week. And I'm like, you understand if he stops when he goes to do the intake, they're going to ask him and they're not going to take him. So he knew from his own history that he needed to pop positive when he tried to get into treatment. So there's a lot of manipulation and things going on in that. And I tried my best to always consider the fact that I was in a courtroom when I'm standing there with that judge. And so I would answer his questions like I would anyone else, with the knowledge that I had limited protections for both of us. So I got really tricky.
We have someone coming off of mute to provide an opinion.
Please, yes.
I believe I unmuted you. Is it? Let me find. My screen keeps going back and forth. Well, maybe I didn't. Frida, I think I unmuted you. It says you're muted. So I'm going to ask you to unmute.
The muted, it wasn't marked there before.
Oh, there we go.
What I would hope to be able to do is to check with an attorney, try to have one in my back pocket at all times if I'm working with clients with substance abuse or any type of criminality, and ask what are the possible scenarios for this young man. If the attorney explains that in this county there are none, then that's what you would have to go with. But he could tell you about some other programs that could help him wean himself off of the drugs while he is learning to be a regular person and getting help to reestablish relationship with his family. That's probably the only way that the drug problem is going to stop. Because at this point, he's doing drugs because he killed his cousin and he's having a hard time living with it.
Absolutely. So I guess to move us along, I'll kind of give you, so ultimately, Frida, you're correct. What it ended up being when you're dealing with a specialty court like that, you have the counselor, the judge, you've got court personnel, you've got a DA, you have a defense attorney. This young man went to jail about 3 weekends in a row, 3 or 4 weekends in a row. Before it was me and the defense attorney that basically said, we have some due process issues here and some other things going on. We need to send him to treatment. He did get treatment. He did ultimately go to the treatment facility that we wanted to go to. And so it turned out well for a time, but then of course he ended up still having his own issues. But you're right. It took the defense attorney. And what's interesting in that situation, the defense attorney, when you're in those specialty courts, was there for 2 people. I could utilize that defense attorney. He would keep me and the client from getting ourselves into any further trouble. So that's where we're at on that one.
And I just want to point out, consultation is not necessarily always with another therapist. Consult with your liability insurance. That's what they're there for. All right, Dr. Dixon, continue. Sorry, I just wanted to say that.
Well, you were actually making the point of this slide.
Yeah,
too,
you were
Dr.
making
Foster.
that's why I clicked it over. I had a little cough fit there, but go ahead.
Yeah, we continually consult, we continually debrief, and we continually ask for the client's consent as we move through the process of supporting them in therapy to find out and make sure that what we are discussing is still okay and still safe for them to discuss, and to let them know what types of things are on the horizon, to share with them what types of things are on the treatment plan that we ideally co-created, and to also let them know that if you don't want to talk about this particular thing today, we don't have to. There are other things that we can discuss to allow them some agency in this space that is designed to support them.
Yeah, I think the only thing I would add is, and I'm sure Dr. E probably has this experience, when you're working with a trauma client like this, and from a trauma-informed way, is the continued consent and debriefing is not only for them, also for you, but it is very common, at least for me in my practice, is we'll have a session. Well, in that session, the homework and the preparation is we're going to discuss this topic next week. How do you feel? They come in and say, are you still comfortable talking about this today? Let's say that they are. And then we're debriefing, we're having this consent to see how far down that little rabbit hole they care to go during that session and in subsequent sessions. And so keep that in mind. You're constantly, continually checking on where they're at if you're going to be truly trauma informed. Oops, sorry. Again, remember, you're not an attorney.
Yes.
Appropriate consultation, proceed with caution. Frida made a good point. Dr. TRW says this all the time. Many of us have our insurance attorneys and our state boards on speed dial to ask all of these questions all the time, because I will not make a legal decision. I know Dr. TRW and the others will not make a legal decision without consulting someone who's an actual attorney and who protects us. And just a little side note, keep in mind, if you're working for an agency, keep in mind that the agency's attorneys are the agency's attorneys. Even though they might benefit you in some degree, you still need your own. That's why we all carry malpractice insurance and follow an ethical decision-making model. And then one more quick case on
The case supervisee. Okay, so I supervised a clinical mental health counseling master's student once who was working with a 13-year-old girl. This girl had been sexually assaulted by an adult male who was connected to her family. And she was assigned to work with this person who I supervised, who was also an adult male. Same race, same hair color. So some things that were kind of interesting, but that's how she was assigned. The supervisor had also shared with me some details about their life that were consistent with a history of sexual abuse, or at least that's how we might categorize it now. But according to him, he was praised because this was, just kind of boys will be boys, sowing wild oats or whatever types of, I guess we'll call them euphemisms, were used with him. This kid was a 13-year-old girl. She did not look 13. You would easily think she was 16 or 17 years old. I sat in on a session with them. It was disturbing to me. the way that they interacted with each other was kind of sexualized. It required some intervention, at least I thought it did. And this girl wore clothing that I could see somebody thinking was kind of provocative. The counselor, and I'm trying to read notes so that I don't take too much time. The counselor, when we were in supervision, told me when I asked about their engagement back and forth a little bit, he's a little dismissive, and he said to me that she looks older than she is, and then went on to say that if given the chance, he would do her. And those were his words that I will probably remember for the rest of my life. And he said when he was a kid growing up, when he was her age, you would get celebrated for bagging a girl like that. So the thing that was really interesting for me, and there were several steps that happened as a result of this interaction. One is we transferred this client away from him. She had to work directly with me, but we had to look at the potential for primary, for vicarious, and for iatrogenic trauma for multiple people in these 3 people involved in this particular session. And I had to think about how I made these decisions ethically. So what I ask all of you is, could my actions as a supervisor further traumatize the supervisee? Could my actions further traumatize the client? What might you consider? Do you want to further traumatize this adult man who may have been sexually exploited as a child? Do you allow him to be in a space where he might be harming her? Like what do you think about doing in a case like this? Because while I found the supervisee's behaviors to be, we'll say, questionable at minimum, this is still a person. So what do you do in a case like this? Does protecting the client potentially cause harm to the supervisee? And if so, does that matter? I hear no one.
No. Anyone, anything in the chat there?
Raise your hand and I'll take you off of mute or pop
Can-
your thoughts in the chat.
Yeah, I got it. Okay. I think the first thing that I think about is, one of the very first things that you learn to become a therapist is that there can be no sexual talk or activity at all between you and a client. So for me, even though there may be some trauma there for him, you could offer him some counseling, but you definitely did the right thing to get the girl away from him, because it's clear that he's not thinking correctly.
Like that, not thinking correctly. It's a very nice way to put that.
Well, he's about to.
And there was a pretty significant age difference there too.
Yeah, he's about to create a dilemma.
My concern too is that he was about to re-traumatize this child.
Right. And she was really the one who came there for care.
Mhm.
And he is supposed to know, because of his profession, that you don't have those kinds of thoughts. And I would hope that if someone had those kinds of thoughts, they would put those thoughts aside and then possibly go to their supervisor and ask for her to be given another therapist.
Thank you. Anyone else?
Someone's got their hand up. Okay, allowed to talk. All right, Dr. Crowley, you've got the floor.
I was going to say, one of the things that I often have to consider myself, teach students and pre-licensure supervisees about, is to be cautious about pathologizing behavior that we may find conflictual with our values and morals, and working really hard to attempt to see, as Dr. Rush-Wilson had said, this is still an individual. This is still someone who, without the connection to this younger female came into our office disclosing some of the same information, we might find ourselves a little more supportive of. And so really trying to look at them as each as individuals and understanding that they each have their own unique histories. They come with their own worldviews and experiences. Not everything is pathologized. And in fact, some things may be rooted more in our own morals and values than in the actual client's perspective on their behavior, their thoughts, their feelings. And let's also remember that thoughts do not always equate to actions.
Very true. Thank you, Dr. Crowley.
Thank you, Dr. Crowley.
Anyone else? You can also hold your thoughts and we can talk about them at the end too. We can move forward. I don't want to leave for Dr. E out. Take away all of what we've been talking about, semantics and language, how you're approaching these things, how you're approaching your clients, how you're understanding ethical decision-making. Sorry, Dr. Escherson. I mean, threw me off. How you are understanding all of these factors we've talked about, all the way from the top, all the way down to where we're at this point, and just kind of how you understand and consult and dig deeper into each one of these things as you have these things happen throughout your career. Dr. E.
Okay, so I'm going to be talking about trauma-informed consultation strategies. And part of understanding consultation strategies, and you can move forward whenever you're ready, Dr. Dixon, is understanding what's the difference in the language of supervision versus consultation. So especially for any students that we might have in the training, we often use these words a little bit interchangeably, but they are different. And it's important to know the difference. With supervision, you are working under your supervisor's license. This is often when you're in field work or when you're gaining your licensure hours before you are independently licensed, and you are really obligated to do what your supervisor says. I mean, hopefully you have a supervisor who's collaborative and uses maybe a Socratic approach and gets you involved. It doesn't just tell you everything you have to do, but you are required to abide by that supervisee's recommendations because it's their license that you're working under. With consultation, this is what we call a very similar process, but when we are not bound by the person we're consulting with or supervising with, we're not working under their license. So we're going to them for their expertise. We're going to them for their recommendations, for their how would you inform me, but we're not necessarily obligated to do exactly what they say. With consultation, this is not even an extensive list here, but we might see it in an individual format where we're saying, hey, I've got this case, kind of like we're doing with these case studies. We're doing consulting when we're talking about the case studies. Got this case and it's tripping me up. And what do you think I should do here? Or, what are the resources? It's very common for professionals to participate in group consultation, whether that is with a designated expert in the area that we're seeking consultation or with fellow peers. So I know, many of us faculty often will do a group consultation on a particular topic. For me, I'm actually involved as a consultee as I'm learning and developing as a brain spotting therapist, working with clients with DID. I've got experience working with DID. I have experience working in general with brain spotting, but I haven't done a whole lot of work putting those both together. So I found a group that is facilitated by an expert in that area, and I regularly participate in that. But we can also talk about consultation, especially trauma-informed consultation on an agency or institutional university, school-wide level, to look at our entire system, to ask, is our system of delivery trauma-informed? So we're going to unpack a few of these things a little more specifically. Okay, so on the clinical side, when we're talking about the unique clinical challenges that come up, again, we might have done a few years of supervision with our pre-licensure supervisor, and a lot of times those are fairly general supervision sessions. You're learning a lot across the board so that you can be able to earn your license in whichever mental health profession you're working in. You can be ethical with a whole bunch of different clients, different topics, populations, etc. But when we're needing a little bit more specifics, like for example, again, using myself as an example, when I built my expanded, let's say, my scope of competence working with DID, that wasn't something that my licensure supervisor had any experience in, but that was an area that I was starting to see clients in, not because I went and sought them out, because that was beyond my competence at that point, but because I recognized it when I had them in session. And so at that point, I needed to reach out and look at who are the experts available to me. And now I'm going to engage in some ongoing consultation with those experts to address the unique challenges with this specific clientele. So these do directly relate to our ethical obligations from the ACA, code of ethics. Again, I'm mentioning scope of competence. And I'd like to mention this one because I think it's important to know that we don't just stick with the competence that we develop in our master's program. We're constantly learning, we're constantly expanding, and clients are going to come to us with continuously complicated topics and challenges that are beyond what we might feel efficacious with from our master's program. So you will be seeking extra consultations so that you can continuously expand your scope. And then, of course, as we've already talked about, the ethical consultation, how necessary that is as one of the primary steps in almost every single ethical decision-making model is consultation and or supervision. So really needing to show that you have reached out to your peers or clinical experts to be informed on what to do. And consultation might be a one-time deal. I've certainly done that several times with cases where it's like, okay, here's this moment in time and I'm totally stuck, and I reach out and find someone who can give me a one-time consultation. Or they might be a relationship similar to the supervisory relationship where you meet every week, every month, or like I was saying with the group consultation, on a regular basis with the same group. I do want to say with the one-time expert consultation, again, learning from my mistakes, it's very valuable to find out who those people might be before you are in a crisis situation. Because when you're sitting here like, oh my gosh, this is going to happen and I have no idea what to do or how to respond. And then you're reaching out to people and say, hey, you don't know me, but can you fit me in tomorrow? It's very hard to do. So in your areas that you're working in, get to know who's the professional organization, who are the training groups, who are the people writing the authors, or who are the authors writing the books or the articles that I'm going to help me learn this. And many times those authors do offer consultation or are part of ongoing consultation groups that you can join. These consultation groups, going into the last bullet there, can also be in a training format. So I'm a part of a consultation training group that talks about organized abuse and trauma. And we have an open, ongoing, kind of closed internet chat site. So you have to be vetted before you are allowed onto it. But then you have the wealth of everybody's expertise. And you can say, hey, here's my question. How have you all dealt with this before? And on the same organization, some of the experts provide, like, here's a 3-part training series if you want to come every Tuesday night. And so just getting to know like all the different avenues that you can seek clinical consultation. And I really recommend doing all of them. You get something different from each one. And of course, the more consultants you can connect with, the more perspectives, the more expertise you're gathering that will, benefit your own development. On the programmatic side of things, so trauma-informed consultations for a program or an institution, we often see these either as we already have a program that exists and maybe it's not working the way we want, or maybe, situations in our society have changed like they have, very clearly in the last 5-ish years, and we need to adapt. So we need to bring in an expert to take a look at our stuff, see where are we missing the mark, does this align with trauma-informed care principles, and how can we make some adjustments? Or we might say we want to build a program from the ground up, and let's involve the consultation in our strategic planning process, in the curriculum development. And there are actually certifications to be a trauma-informed certified program agency. And these aren't specific to mental health. The school systems, businesses, hospitals, community centers, and of course, mental health centers, we would hope would be seeking this trauma-informed consultation to guide them. Okay, ready for the next one. So then talking about some of the specific strategies that we might see in either this clinical or programmatic approach. In a clinical approach, we already talked about what's different from supervision, but we still want to identify what's the goal of consultation of this. If it's a one-time, what do I need to get in this one meeting? Here's the issue. What's the scope of it? Like, am I needing to find a referral, or am I needing to just identify this one? I'm not sure what to do here. And how long does this consultation then need to be? Because if I'm going thinking as a consultee and I'm going to my expert consultant saying, I just want one session, but here, and then I start unpacking all the stuff, it would be appropriate for the consultant to say, this is beyond the scope of one session. We're going to need some ongoing stuff, whether that's regular consultation or come on and join the ongoing group that we have and have regular. And Dr. Dixon, I think the slide maybe just popped forward. Thank you. So that's also part of assessing the issue and the topic to understand what's the scope here. Part of doing that is very important for the consultant when you're in the consultant role to still get to know a little bit about your consultee, even if it's a one-timer. Understanding, again, trauma history, how long have you been struggling with this? What's the history of your experience in the profession, your work with this client, and understanding that contributing component of the consultee in the dilemma is really important. And then, of course, it's the provision of the expertise of, okay, the consultant has hopefully been where you're stuck and can offer some different resources, suggestions, awareness of pitfalls, some guidance. Also really important in a clinical consultation to make room for countertransference responses, counter-trauma responses, and vicarious trauma reactions. When we're working in the traumatized population or with clients who have experienced trauma or survived trauma, those elements are part of what we experience and are often major contributors to whatever the issue or the dilemma is that we're facing. So as a consultant, make sure you are aware and bringing that into the conversation with your consultees. And then on the flip side of that, we also want to explore vicarious resilience, post-traumatic growth, and counter resilience. So these concepts of, while working, especially over a long period of time, the exposure to our clients' trauma narratives, trauma responses, even just the awareness of how traumatizing the world is, that can very much start to weigh on us and develop our own trauma response or vicarious trauma response with one or more clients. But at the same time, and I imagine you could ask any of us, why are you still working in this area then, if it's so traumatizing for the people who work in it? But it's also there's a vicarious resilience and optimism and empowerment that we feel in witnessing and partnering and journeying with our clients to see, like, actually, it's the most meaningful work I could do. Like, yeah, I'm exposed to stuff I never would have wanted to know. And at the same time, I'm exposed to more resilience in my clients than I could have ever thought possible. So we have both of these experiences when we're working in the trauma area. So all of that should be a part of a clinical consultation strategy. Okay, now I'm ready, Dr. Dixon. And then on the programmatic side, some strategies, again, we're doing a needs assessment, and we're doing a lot of program evaluation pieces here. So what are the needs of this agency or this organization that we're either working to enhance or that we're working to build? What are the goals? Are there any current policies or practices that are actually traumatizing to the consumers? So we want to start with, like, is there anything here, like the red flags that we want to jump on first and say, we definitely need to adjust those. We want to identify who the stakeholders are. And in a trauma-informed agency approach, the stakeholders include the consumers. So we want to make sure that their voices are a part of this, of the building or of the revision of a program. When we're offering this initial consultation, we also want to not just say from the beginning, okay, we've evaluated your program or we've influenced or informed your strategic planning. Now, good luck, go do it. We want to be involved in the whole process. So that means coaching through the implementation of the trauma-informed initiatives. And that also means offering follow-ups. So it might be 3 months, it might be 6 months or a year. How is this all working? Because if it's not working, then that's not going to be trauma-informed anyway. So, continuing to listen to the voices of the stakeholders, consumers and providers is important for that follow-up. And we want to ground the consultation, of course, in those 6 trauma-informed principles that Dr. Foster presented. And there's also the 4 R's are also inform a trauma-informed approach. So the 4 R's are realizing that trauma is pervasive, that it's not going to just be like once a year, maybe I'll get a client that talks about trauma. It is embedded in our society. Being able to recognize the signs of trauma and all the different signs of trauma, like we've talked about already. It's not just flashbacks and nightmares. It shows up in all kinds of different ways. Responding to trauma through a trauma-informed care approach, and resisting the re-traumatization by employing trauma-informed principles. Then we also need to be considering not just our consumers or our clients, but how is trauma experienced by the providers in the organization. So how are teachers showing their own experience of trauma these days? How are our mental health professionals in this agency dealing with the trauma? Are they showing any signs? Is there anything in our practices that are actually traumatizing or re-traumatizing to them? And so looking at it from a parallel process point of view. And then a huge part of trauma-informed consultation includes educating all the stakeholders, especially the staff. So you might not have clients involved in these trainings or curriculum, but especially the staff and the leadership. So very common topics for curriculum or training components would be Trauma 101, of course. You can't assume that the CEO has the same level of trauma awareness as the mental health providers, and they might still not have the same, but everybody needs to have at least the basics of what is trauma. Included in that is understanding adverse childhood experiences and how those contribute and show up for our clients. The trauma informed basics, cultural responsiveness, as we've already talked about, historical trauma, compassion, fatigue, resilience, and of course, lots of other topics, but I think we've touched on a lot of those pretty well. Okay, we're ready. And so the takeaway is, and this might be daunting for some of our students or recent alums here, but you're never done learning. So even if you're like, I'm almost done with my program, yeah, but no. And coming into this profession and staying in this profession with an attitude of, I will constantly be needing consultation. I will also be able to provide others with consultation. But this is not just for ourselves or our clients, but our entire communities to try to make this trauma-informed impact on all of the systems, including the direct work we do with our clients. And I don't know, is this my case study, Doctor? Yeah. Okay, all right, so I've got some notes for my case study. And my case study is not necessarily a one specific case from my experience, but a bit of a conglomeration. So, and it's a 2-parter. So let's see. All right. So consider a licensed professional counselor. It can be a licensed social worker, but a licensed mental health clinician who's working in a school setting. And they are working as, gosh, they have a lot of hats that they're wearing. So they often go into the classes and offer some trainings on resources and coping skills, but they also are able to see students not just in a like in a guidance role, but in a clinical role as well. They're able to see a few students on an ongoing basis for clinical counseling. What they've been noticing over the last few years is that the severity of the emotional and behavioral issues or challenges in the students seems to be increasing. They've worked in the school for many, many years. They haven't seen it to this level. So that might be, clients just getting reactive in class, having a hard time calming themselves down, getting into conflict with one another, having conflict with teachers, substance use, depression, anxiety are some of the main things that they are seeing a lot more of. They're also noticing that the referrals that they're getting from their teachers sending students to them is increasing. So sometimes the teachers are sending them in a kind of a formal referral process, having talked to the students saying, it seems like you might, benefit from talking to counselor so-and-so. And sometimes they're in kind of a crisis type of situation, like you need to leave the classroom and I'm sending you down to the counselor's office. So there's not a whole lot of consistency in those referrals, except that there's more coming in. So one day, one particular student who this counselor knows and has had a relationship with, but not necessarily a clinical counseling relationship, but they've had a relationship over the last few years. So they've continued to have issues, and this is from the teacher's report, they continue to have escalating issues in the classroom. They're no longer turning in their assignments. They're no longer interacting with the friends that they used to have. They're getting into conflicts with some peers in the classroom. They seem very despondent in class. They have sometimes fallen asleep in class and really just totally disengaged. And the teacher did overhear them then talking a little bit about wanting to hurt themselves. Wasn't defined what that meant, but that was the language that the teacher is using for the referral. This licensed mental health professional has done a master's level trauma course as part of her curriculum. And she, did get the clinical experience to gain her license, but she has not done much more trauma specific training beyond that. So she initially, in working with this client, she initially is thinking, gosh, this might be out of my scope. She talks to the client or the student and says, could we find someone to refer you to who might specialize in an area, that might seem to fit what you're experiencing? And the student says, no. First, I refuse to see anybody else. My family can't afford to go outside of the school, and you're the only one that I trust to talk about what's going on. Let's see. Okay, so that's the end of part one. So at this point, if you're the licensed mental health professional, what do you do?
And for the sake of time, let's put the answers in the chat if you have an answer.
Okay, and then I'll go on to part two for the sake of time. Yeah, I need to speed this up. So part two then, as people are putting their answers in, the counselor is noticing, all right, this is not just this student showing this increase in distress. I'm noticing that this teacher that referred the student is in distress. In fact, I'm noticing that all of the teachers and all of the paraprofessionals and even the administration, just everybody has a shorter bandwidth these days. We have fewer, or I should say we have more teachers calling out sick, which then puts, it's taxing on the rest of the teachers. We have more families that are experiencing housing, food insecurity, safety issues in their community. We're seeing this across the whole system. And so thinking again for the part two, yes, we want to support this professional mental health provider, but there's another level. And so that part 2 is how could we support this system from a trauma informed? If we were the consultant that was called in, how might we want to support them? So I welcome any input, recommendations, or thoughts you might have on what a school system like this might benefit from for all of those consumers.
I was typing my answer in the chat. I was going to say, have we conducted a needs assessment?
Not yet, but we could.
We might need to.
I need to, as the consultant coming in, that would probably be one of your first steps. And think about who you would be asking. What are your data sources for that needs assessment? Are you just observing what's going on? Are you interviewing? Are you looking at documentation?
I think it has to be a 360 approach. It goes back to the assessment questions in the beginning, that fishbowl. In order to be able to answer all of those questions about what's really going on, we need to observe, document review, stakeholder input, survey. It could be a variety of things.
Absolutely.
It has to be systemic.
Yep, systemic, person-centered, trauma-informed, culturally informed. Okay, well, I know we're getting short on time, so we can close the case, and of course, people can still add their thoughts in the chat, but feel free to move on.
And just a nice takeaway from today. Again, just because you can doesn't mean you should. There's a fine line between right and wrong. What ended 1896? 1895 did. Dr. Dixon, you can just close out and we can look at questions at this point. We have about 5 minutes. Any questions that come up for you all, you can pop them in the chat. We did get a question about whether or not we would be willing to share our slides. We did record the presentation, so you'll have access to the slides through the recorded presentation. Any other questions? To that live. Thank you. When and where do we access the presentation? That is a Colleen Malone question. Or a Chris question.
Yeah.
I was trying to see if Colleen was still here. They will post it to their YouTube page.
Okay.
So we post it to the YouTube page.
And just as a reminder, participants interested in getting continuing education, you have to complete the program evaluation for this and meet the attendance requirements. The attendance requirements are a minimum of 45 minutes of an hour session, an hour and 45 of this 2-hour sessions. The evaluation will be sent via email using email used to log into today's presentation. Well, thank you all so much for deciding to spend your time with us. We really appreciate the captive audience. And Colleen even popped in the chat our YouTube page where you can go look at lots of things, including past conference submissions. Thank you all so very much.
Thank you.